for this 37th online teaching class under the banner of Up-Aroi. And I would like to request Dr. Shalin sir to introduce our today's speaker, Dr. Pramod Gupta.
Right. So good evening, friends. Dr. Pramod is he's a postgraduate. He's a graduate from KGMC, and he's a postgraduate from SGPGI. And after that, he's done periods of senior residency at SGPGI and also at the Tata Memorial and at another center. And he's currently on the staff roles of the Kalyan Singh Super Speciality Cancer Institute. And Dr. Pramod, I would urge you to briefly introduce your institute. It's the new on the horizon of the state of Uttar Pradesh. So just very briefly as a preamble before you start your talk. So over to you, Pramod. Please, the stage is all yours.
Good evening, everyone. It's my pleasure to get introduced by my guru, my teacher, Professor Kumar sir. And he is a founder director, first permanent director of this institute, Kalyan Singh Super Specialty Cancer Institute. It is a state-of-the-art cancer institute, approximately 1,250 bedded when fully functional. We have at present around 500 beds. Of this, around 100 beds are functional, and we have 6 teletherapy bunkers and 2 brachytherapy bunkers, and we have 24 modular OTs. So it is a very big, ambitious project of state government, and we hope we will be serving more and more patients in near future. So at the outset, I would like to thank Professor Surbhi Gupta ma'am also for giving me opportunity to present this lecture, and the talk for today is management of locally advanced and metastatic prostate cancer. So I have briefly given the outline here. I shall be discussing first with the locally advanced high-risk prostate cancer management, and it is almost similar like localized prostate cancer, like surgery and radiation, pros and cons of surgery, role of salvage RT, early RT, post-surgery, and then radical RT, its technique, indication, dose, and fractionation. So all this has been discussed in great detail in the previous class by Professor Neeraj Astogi. So I shall not be dealing with the RT techniques and dose fractionation. However, for extreme hypofractionation, that is SBRT practice, what is being done in India, I shall be discussing. And then I shall be discussing management of non-metastatic hormone-sensitive and metastatic hormone-sensitive prostate cancer, and then management of non-metastatic castration-resistant prostate cancer and metastatic castration-resistant prostate cancer. So as we have seen in the previous classes, prostate cancer has been divided into 3 groups, basically low, intermediate, and high risk. However, NCCN has 2 more classes, very low risk and very high risk. The classical high risk include PSA more, DM-ECO classification includes PSA more than 20, Gleason score more than 7, and clinically T2C or 3 ADGs. However, in NCCN very high risk, it is at least one of the following should be there, that is clinically T3B or T4 disease, primary Gleason pattern 5, 2 or 3 high risk patterns, and more than 4 cores with grade group 4 or 5. Why this very high risk is important? Because if you read many papers or trials, we find even from India, they have included very high risk group, even from Tata Memorial. So one need to know about this. So coming to management of locally advanced high risk prostate cancer, this is the ESMO guideline published in 2020, and it is almost similar like localized prostate cancer, where the surgery and radiotherapy is option. However, in localized high-risk prostate cancer, if you do surgery, there is high risk of margin positivity, especially in the apex of tumor. So in general, neoadjuvant androgen deprivation therapy for 4 to 6 months, followed by radical RT along with ADT, and followed by long-term ADT for 2 to 3 years is the standard of care. So androgen deprivation therapy is not a new thing. Way back in 1941, Charles Higgins, he found that prostate cancer is an androgen-driven or dependent tumor, and with ADT, that is surgical or medical castration, we can see the decrease in the size of prostate gland or prostatic cancer. For this finding, he got even Nobel Prize in 1966. So what are the various options for androgen deprivation therapy? One is surgical, that is bilateral orchidectomy. Another is medical, that is LHRH agonist alone, or LHRS agonist along with the first generation anti-androgen like bicalutamide, or LHRS antagonist like dijarelix, and combination of like bilateral orchidectomy plus abiraterone, or LHRS agonist plus abiraterone or digarelix abiraterone. The surgical option include bilateral orchidectomy. And the advantage are simple. It is a simple surgical procedure with rapid and pronounced reduction of testosterone, and it's having low cost. The disadvantage is like it's irreversible with negative psychological impact, and there are permanent side effects like vasomotor, sexual, metabolic, or cerebrovascular side effect. And elevated FSH that may be associated with cardiovascular side effect. What to choose between LHRS agonist and antagonist? LHRS agonist, they have initial surge in FSH, LS, and testosterone, and with prolonged suppression followed by prolonged suppression of luteinizing hormone and testosterone. And there can be potential microsurges of LH and testosterone with repeat injection. While with LHRS antagonist, there is rapid suppression of FSH, LS, and testosterone followed by prolonged suppression of FSH, LH, and testosterone. So if we see the cardiovascular side effect, patients having treated with LHRH agonist, they are having more cardiovascular events or side effect as compared to those treated with LHRS antagonist, and survival probability is less. And those patients who are having baseline cardiovascular disease, the difference is further more. The survival probability is lesser with LHRS agonist. However, in practice, we see the LHRS agonist like leprolide or goserelin, they are in more commonly used. So coming to the options of radiotherapy prostate cancer, I shall be focusing on only high risk, that is according to NCCN or DMECO classification. The radical radiotherapy along with long-term ADT is standard of treatment. And the dose and fractionation has been conventional with dose escalation like 74 to 78 gray at the rate of 2 gray per fraction, with moderate hypofractionation 60 to 63 gray, 2.7 to 3 gray per fraction. And there are also extreme hypofractionation like SBRT, where 37.5 to 40 gray and in 5 to 6 fraction has been used. So the conventional fractionation and moderate hypofractionation was possible in prostate cancer because we know the BD is comparable, and the assumption is that alpha beta ratio for prostate is 1.5 gray for tumor. So like in breast, where the alpha beta ratio is less, there are many trials showing equivalence or better result with moderate or ultra hypofractionation in prostate cancer. So is there evidence or Indian data using SBRT in high-risk locally advanced prostate cancer? Yes, we have. From Tata Memorial, Mumbai, Dr. Vedang Murthy et al. Has published early results of extreme hypofractionation using SBRT for high risk or very high risk and node positive prostate cancer. Remember, very high risk are where it's T3B or T4 disease and primary Gleason score 5. So they have published that in 68 patients with a median follow of 18 months, the OS was 97% and the biochemical relapse survival was 94%. They have treated prostate and gross node with 35 to 37.5 gray in 5 fraction alternate day, and in node positive patient, pelvic RT was given in 25 gray in 5 fraction alternate day. And toxicity was also less. Grade 3 toxicity was 3% GU, and GI toxicity only no GI toxicity. So another phase 1 and 2 study from Tata Medical Center, Kolkata, published by Dr. Indranil Malli. It's a stereotactic hypofractionated once weekly RT short study. So they have included localized prostate cancer, with all risk group, that is PSA, but PSA less than 60, and they have treated with 35 grain 5 fraction once weekly with IMRT or rapid ART treatment. And ADT was given for 2 years in this trial. So with 40 months follow-up period, we can see the grade 2 plus GI and GU toxicity is only 6.7%, which is comparable, even lesser with the published literature in the world, like Saturn and Patriot trial. So with median follow-up 41 months, this trial has shown excellent biochemical and clinical control rate 97 and 88%. There was no cancer-specific mortality, and 3 and 4 year overall survival was 96%. And acute toxicity rates were extremely low. So based on that, a phase 3 randomized controlled trial is being done in India, that is called PRIME trial, and it includes high risk or node positive prostate cancer. It is being done in 2 centers, Tata Memorial Mumbai and Tata Medical Center Kolkata. It compares moderate hypofractionation, 68 grade 20 fraction in 5 weeks versus 36.25 grain 5 weeks alternate day over 10 days in Tata Memorial Mumbai versus in Tata Medical Kolkata. It is 62 grain 20 fraction in 4 weeks and 36.25 grain 5 fraction in 29 days. This is weekly, like day 1, day 8, 15, day 22 and day 29. So a weekly treatment. So we can conclude that hypofractionated radiotherapy has a strong radiobiological and clinical basis. Moderate hypofractionation can be considered as a standard of care in all risk group, and there is evidence for safety and efficacy in node positive patients. In ultra hypofractionation for SBRT, there is evidence for safety and efficacy in phase 2 trials, and there is phase 3 safety data in low and intermediate risk in phase B study already, and there is a phase 1 and phase 2 safety and efficacy data in high risk, like SALT study from India. And this PRIME trial, ongoing RCT, is going on, showing ultra hypofractionation and extreme hypofractionation. So in future, we may have a standard of care with ultra hypofractionation. So in order to increase the overall survival in locally advanced high-risk prostate cancer, that there has been studies to include or give chemotherapy. And it has shown that addition of chemotherapy, basically docetaxel or taxane-based chemotherapy, has shown improvement in disease-free survival or relapse-free survival, like RTOG 0512, GET-12 or STAMPEDE trial. And RTOG 0512 has shown improvement in overall survival also, although median follow-up was only 5 years and long-term follow-up is needed. And one of the reasons in this study may be because it has 84% of the patient who has Gleason score more than 8 as compared to GETAC, where it was only 42%. So this is the meta-analysis published in Lancet Oncology 2016 by Vale et al. And we can see there is improved survival, a trend towards improved survival with addition of docetaxel, and there is absolute reduction of 4% failure rate of 8%. It was statistically significant. So further studies included integration of novel hormonal therapy like abiraterone, acetate, or enzalutamide, along with the standard of care, that is radical RT and androgen deprivation therapy. So this is one arm of the STAMPEDE trial. I shall be discussing again this study. It includes abiraterone acetate plus prednisolone with or without enzalutamide added to standard treatment, that is ADT, compared with the ADT alone in high-risk non-metastatic prostate cancer. It has 2 arms, standard of care, that is RT plus ADT followed by ADT for 3 years. And in second arm, it was standard of care followed by abiraterone for 2 years. And another arm, it had abiraterone plus enzalutamide for 2 years. So roughly 2,000 patients, the median age at randomization was 68 years, median PSA was 34 nanogram per ml, and around 39% of patients were having node positive disease. All the N0 patients, nearly all have undergone local RT, and 70% of the patients underwent RT who had node positive disease. And the median follow-up was 6 years. So it has shown that at 6 years, metastasis-free survival improved from 69 to 82%, with addition of abiraterone with or without enzalutamide. And OS also increased from 77% to 86% at 6 years. However, increased OS benefit always comes with increased toxicity in these trials. And we can see that with ADT alone, nearly 1/4 of the patients were having grade 3 toxicity. And with abiraterone, 1/3 of the patients were having grade 3 toxicity. And with addition of two drugs, that is abiraterone plus enzalutamide, nearly half of the patient had grade 3 toxicity. There was no grade 5 toxicity in the ADT alone arm, whereas 1% of the patient developed grade 5 toxicity with either abiraterone or abiraterone plus enzalutamide. So these are the latest NCCN guidelines. In this also we can see for high risk or very high risk group, the patient having more than 5-year expected survival or patient who are symptomatic. It recommends standard of treatment is radical RT plus androgen deprivation therapy or radical RT along with brachytherapy plus ADT. For very high risk patient, addition of docetaxel or abiraterone can be done to standard of care. Second treatment is, as we discussed earlier, radical prostatectomy plus pelvic lymph node dissection, and post surgery, depending on lymph node metastasis, rising PSA level, adjuvant treatment can be given. It is almost like similar to localized prostate cancer discussed in the previous lecture. For patients having less than 5-year expected survival and those who are asymptomatic, treatment options are observation or ADT or radical RT alone. For patients having node positive disease and having more than 5-year survival or those who are symptomatic, again the standard of treatment is radical RT plus ADT, or in some cases, high risk cases, abiraterone can be added. And for those patients who underwent surgery, the treatment remains same as like N0 disease. And patients having less than 5 years expected survival and those who are asymptomatic, they can be kept on observation or ADT. So in conclusion, for high risk locally advanced prostate cancer, we can see addition of 2 to 3 years of ADT along with radiation. It remains the standard of care. And with addition of chemotherapy, especially in very high risk patients, we can see some overall survival benefit. However, at the cost of increased toxicity. Similarly, addition of 2 years of abiraterone is showing benefits in many trials, and it can be given in very, very high risk prostate cancer with some more toxicity. So this slide depicts the different states of prostate cancer. Initially, many patients present with the clinically localized disease. We offer them localized treatment in form of surgery or radiotherapy along with ADT. Some of them are cured, some of them in future develops rising PSA level. With rising PSA, they can present with two forms, with non-metastatic disease, which are hormone sensitive, and they can present also with metastatic hormone sensitive prostate cancer. The non-metastatic hormone sensitive disease can progress into, with or without treatment, into non-metastatic castration-resistant prostate cancer, while the metastatic hormone-sensitive prostate cancer can progress into non-metastatic castration-resistant prostate cancer. And some patients, de novo, can present as a metastatic hormone-sensitive prostate cancer. So how we manage non-metastatic hormone-sensitive prostate cancer? There is a controversy about the timing and duration of ADT, when to start, when the local therapy in form of surgery and radiotherapy has failed and there is increasing PSA level. There is a group of institutions who believe that initiation of early androgen deprivation therapy is best, but it is associated with increased toxicity if we start early ADT. And patients with an increasing PSA level and with no symptomatic or clinical evidence of cancer after definitive treatment present a therapeutic dilemma regarding the role of ADT. So timing of starting of ADT, in patient where only evidence is there is no metastasis, patient is asymptomatic but having increasing PSA. It depends on PSA velocity, that is measured in terms of PSA doubling time. If it is PSA doubling time is less than 8 to 10 months, it is believed to have aggressive disease and early ADT can be started. It also depends on patient and physician's anxiety, the short-term and long-term side effects of ADT, and underlying comorbidity, performance status of patient. So early androgen deprivation therapy is acceptable, but an alternative is close observation until progression, when other therapeutic options can be offered later. So according to NCCN also, for castration-naive prostate cancer or non-metastatic hormone-sensitive prostate cancer, monitoring or observation can be preferred. In some patients in high risk, ADT can be given. And ADT can be offered along with the other agent like abiraterone, epilutamide, docetaxel, or enzalutamide. These are category 1 recommendations. So coming to management of metastatic hormone-sensitive prostate cancer, we can divide the metastasis burden in prostate cancer into 2 groups. Okay. Low burden or low volume disease versus high burden or high volume disease. In low burden or low volume disease, the lymph node metastasis is present and or less than 4 bone mets and without any visceral metastasis. While the high volume disease, there are more than 4 bone mets and or visceral metastasis present. So, sorry. Excuse me, my slides are not moving. Just a minute. Yeah. So if you look at the history of development of systemic treatment for non-metastatic or metastatic hormone-sensitive prostate cancer, it starts with 1941 with Charles Huggins developing ADT. In 2009, bicalutamide have shown improvement in OS. In 2015, charted in one arm of the STAMPEDE trial has shown addition of docetaxel improves overall survival. In 2017, another arm of STAMPEDE trials and Latitude have shown addition of abiraterone along with ADT results in improvement in overall survival. And we have seen in 2019, 3 trials, Titan, Archie, and Enjamet, they have shown addition of epilutamide, enzalutamide to androgen deprivation therapy, resulting in improvement in OS. And latest, in 2021, there is a trial called PEACE-1, where both abiraterone acetate and docetaxel has been added to ADT, resulting in improvement in OS. The first trial is CHARTED trial. It has shown chemohormonal therapy in metastatic hormone-sensitive prostate cancer. Patients were divided into 2 groups, ADT plus docetaxel versus ADT alone. Roughly 400 patients in both the group. And it has shown survival advantage 57 months versus 44 months with addition of docetaxel. And it was significant. And we can see the benefit was more with the high volume disease in the overall survival as compared to low volume disease. However, increased overall survival comes with increased toxicity also, and we can see the grade 3 and grade 4 toxicity are higher. The neutropenia is 9%, grade 4, febrile neutropenia 2.3%, and infection with neutropenia 1%, grade 4. So this table summary shows the 3 trials, GETEC 15, CHARTED, and STAMPEDE, showing improvement in OS, 54 versus 58 months, 44 versus 57 months, and 45 versus 60 months, with addition of chemotherapy, docetaxel. And this meta-analysis published in Lancet 2016, there is improvement with addition of docetaxel is standard of care in OS. The other trials are Latitude trial. They have compared abiraterone 1000 milligram along with prednisolone with and ADT versus ADT alone. And there is improvement in overall survival at 4 years. And in the Asian subset also, there is overall survival improvement, and adverse effects are comparable. Another study is Titan study. They have compared apalutamide versus and ADT versus ADT alone. And there is again improvement in median OS, 52 months versus 39 months. And this Archer's study has compared enzalutamide 160 milligram per day along with ADT versus ADT alone. And again, there is overall survival benefit 71% versus 57% at 4 years with addition of enzalutamide. So we can see that in DNO, high volume metastatic castration sensitive prostate cancer or metastatic hormone sensitive prostate cancer with ADT alone, the survival is around 33 to 35 months. When we add chemotherapy in form of docetaxel, the improvement is of roughly 10 months, 40 months, 48 months as compared to ADT alone. And with addition of abiraterone, the overall survival becomes 50 to 56 months. So in conclusion, we can say that ADT with treatment intensification is the preferred for most patients with high volume metastatic prostate cancer. And those patients where the performance status is not good, risk of toxicity is higher, comorbidity is present, we can also give ADT alone. So is there any role of radiotherapy also in metastatic hormone sensitive prostate cancer? Earlier, it was thought that there is no role of radiotherapy in the metastatic disease. But this trial, Pramod trial, has shown the effect of survival of ADT alone compared with ADT with RT in patients with primary bone metastatic prostate cancer. Trial compared around 200 patients in each arm with ADT alone versus ADT plus RT. The median age was 67 years and the Gleason score was 8 and 9 in roughly 60% of the patient, and the T stage was 3 and 4 in roughly 70% of the patient, both the arms. And less than 5 lesions was seen in 41% in radiotherapy arm, where in ADT alone it was 33%. It has shown that overall, if we see, there is no significant benefit. But if we look at low burden disease with number of mets less than 5, there is an improvement in overall survival. So this was the basis for Stampede study, and it generated with the hypothesis that radical RT to the prostate will result in improvement in overall survival, especially in patients with low burden disease. And Stampede stands for Systemic Treatment in Advanced or Metastatic Prostate Cancer, Evaluation of Drug Efficacy. It is a multi-stage, multi-arm trial. Results were published in Lancet 2018. It's a sort of practice-changing paradigm shift trial. It is a phase 3 trial conducted UK and Switzerland in more than 100 hospitals. Eligible patients had prostate cancer that was newly diagnosed with no obvious radical treatment and had metastatic disease confined on a bone scan and soft tissue imaging done within 12 weeks of starting ADT. And all patients were intended for long-term ADT and started treatment no earlier than 12 weeks before randomization. And there were no age restrictions. Patients were required to have no contradictions to RT and no clinically significant cardiovascular history. This Stampede trial is like Octopus. It has a multi-arm and multi-stage trial. It has around 7-8 arms. Arm A is standard treatment, that is long-term ADT and with RT for some men. And arm B is standard treatment plus zoledronic acid. Arm C is standard treatment plus docetaxel. Arm D is standard treatment plus celecoxib. Arm E is standard treatment plus zoledronate plus docetaxel. Arm F is standard treatment plus zoledronate plus celecoxib. And for their further arm G, H, and J. And they have more than 2,500 patients. So we can see that for RT, they have included around 2,000 patients and roughly 1,000 patients in both the arms, standard of care with RT and without RT. The median age at the randomization was 68 years in both the groups. T3 and T4 lesions were around 90% in both the groups. Node positivity was seen in 2/3 of patients in both the groups. And low metastatic burden was seen in around 40% in both the groups. Bone was the most common site of metastasis, around 90% of the patient, and in around 30% distant lymph nodes metastasis was present. Gleason score 8 to 10 was seen in 80% of the patients, and PSA was around 100 in both the arms. And the weekly and daily radiotherapy schedule was given in roughly half of the patient in each arm. The weekly schedule was 36 grain 6 fraction over 6 weeks weekly, 6 grain per fraction weekly, and the daily arm was 55 grain 20 fractions over 4 weeks, and RT was given to prostate only. We can see that there is improvement in OS in the low burden disease, and improvement is 73% versus 81%, 8% benefit in 3 years, where there is no significant benefit in the high burden disease. And in this forest plot also we can see there is improvement in low burden disease with addition of radiotherapy. Coming to the toxicity, it was similar in both the group, weekly versus daily. Acute grade 3 and 4 toxicity was 5%, whereas it was 1%, roughly 1% toxicity, lead toxicity in both the group. So we can say that addition of radiotherapy in the low metastatic prostate cancer having hormone sensitive disease, it results in improvement in overall survival. The stopgap IPD individual patient meta-analysis, it has also shown that there is 7% improvement in the 3-year overall survival in patients having less than 5 bone mets. So NCCN also recommends addition of EBRT to low volume metastatic castration naive or hormone sensitive prostate cancer. So in summary, the treatment landscape for metastatic hormone sensitive prostate cancer is evolving rapidly with so many new drugs or treatment option permutation combination is being tried, and treatment selection depends on many factors. It also includes logistics, including cost of the treatment, accessibility of drug. Many drugs are even not available in India, very costly. Patient factor, most of these patients are old age patients with comorbidity, performance status is poor, they have, and there are other disease related factors also. And for low burden or low volume metastatic hormone sensitive prostate cancer, post-stampede, there is a role for addition of local RT, either daily or weekly. So now coming to the management of non-metastatic castration-resistant prostate cancer. So what is non-metastatic castration-resistant prostate cancer? If we see development of prostate cancer, so many patients present with the initially localized or locally advanced prostate cancer. We offer them localized radiotherapy or surgery all along with the ADT, and some of them had no relapse and some of them will have relapse in future. Relapse can be in form of rising PSA only, or local relapse, or distant mets, or in combination of all the three. Those patients who are having only rising PSA, patient can be kept on watchful waiting, or androgen deprivation therapy with other treatment can be started as discussed earlier. In spite of that, some of them will have persisting rising PSA or on progression rising PSA. So these are defined as non-metastatic castration-resistant prostate cancer. And those patients who are not suitable initially for any localized treatment, they are usually offered ADT along with the other treatment. In spite of that, after some time or immediately, they can have rising PSA and they can go into non-metastatic castration-resistant prostate cancer group. So standard definition of non-metastatic castration-resistant prostate cancer is when there is a rising PSA with castration level of testosterone that is less than 50 nanogram per deciliter, and there should be no detectable disease on conventional imaging like radionuclide bone scan on CT abdomen and pelvis with or without MRI. It does not include PMSA scan. And the inclusion criteria for clinical trials has included only high-risk non-metastatic CR PC, that is PSA doubling time less than 10 months, and PSA 2 nanogram per ml or greater. So is there any relation between PSA doubling time and risk of metastasis? In this graph, we can see when the PSA doubling time decreases from 20 months to 8 to 10 months, there is a sudden increase in risk of metastasis and prostate-specific cancer death. So lower the PSA doubling time, higher the risk of morbidity, metastasis, and prostate cancer-specific death. So these are the three important trials, Prosper, Spartan, and Aramis. They have shown improvement in overall survival or metastasis, basically metastasis-free survival from 16 months to around 35 to 40 months. However, there is no improvement in overall survival. The reason is clear because we have so many lines of salvage treatment. So even if patient develop biochemical metastasis failure, we have salvage treatment option. But they have clearly shown roughly double or 2.5 times improvement in biochemical metastasis-free survival. So in Prosper study, it compared enzalutamide plus an ADT compared with ADT alone. Median PSA doubling time was 3.8 months in both the arms, and it has shown improvement in metastasis-free survival 14 months versus 36 months. In a Spartan study, it compared apalutamide along with ADT versus ADT alone. The median PSA doubling time was less than 6 months in roughly 70% of the patient, and 1/6 of the patient were having node positive disease. And it has shown that 72% risk reduction of distant progression or death, and 30% risk reduction of death. In Aramis trial, it compared 1200 milligram darolutamide along with ADT versus ADT alone. The PSA doubling time was less than 6 months in around 70% of the patient in both the groups. And it has shown that 59% risk reduction of distant metastasis or death and 31% risk reduction in the overall survival. So we can see, however, in all this trial, Prosper, Spartan, and Aramis, in Prosper with enzalutamide, 1/3 of the patient had grade 3 or 4 toxicity, where in Spartan with apalutamide, they had roughly half of the patient developed grade 3 or 4 toxicity. And with darolutamide, 1/4 of the patient developed grade 3 and 4 toxicity, which is quite high. And in all the three trials, 1/10 of the patient treatment was stopped due to adverse toxicity. So according to NCCN also for non-metastatic castration-resistant prostate cancer, patients should be offered continuation of ADT to maintain castrate serum level of testosterone, and patient having PSA doubling time more than 10 months, they can be kept on monitoring or they can be offered secondary hormone therapy. While the aggressive patients were having aggressive disease with PSA doubling time less than 10 months, any of the category 1 recommendation are for like apalutamide, darolutamide, and enzalutamide. So coming to the metastatic castration-resistant prostate cancer, they can develop from non-metastatic castration-resistant prostate cancer developing into metastasis, or they can also develop from metastatic hormone-sensitive prostate cancer. There are many systemic agents available now, starting from androgen receptor pathway inhibitors like enzalutamide, abiraterone, apalutamide, darolutamide, taxane-based chemotherapy like docetaxel, cabazitaxel. Recently, radionucleotides like radium-223, which is a calcium analog alpha emitter, and lutetium-177 PMSA, and PARP inhibitors like olaparib, rucaparib, and some cases immunotherapy like Sipulixel-T. So in metastatic CRPC, we have multiple lines of treatment: first line, second line, third line, fourth line. And depending on the previous treatment, different drug can be given. And there are phase 3 trials which has shown improvement in the overall survival with addition of docetaxel, enzalutamide, abiraterone, cabazitaxel, and so on and so forth. So this is a trial showing efficacy of radium-223, L-SIMCA trial. It included confirmed symptomatic castration-resistant prostate cancer patient with more than or equal to 2 bone mets and with no known visceral metastasis. Patient was randomized to radium-223, given 4 weekly for 6 cycles, followed compared along with best standard of care versus best standard of care alone. And has shown 4 months improvement in OS, 15 months versus 11 months. So another new drug is lutetium-177 PMSA. Prostate-specific membrane antigen is a type 2 transmembrane protein overexpressed on the prostate adenocarcinoma cells. And labeling small molecule inhibitors of PMSA with radioactive lutetium-177 is increasingly being used for therapeutic treatment in prostate cancer. So there is a trial called Vision trial. It included novel patients, those who are treated with novel hormone treatment and taxane-based chemotherapy. In that patient, those group of patients with the standard of care, lutetium-177 was added. It has shown roughly 4 months in the median overall survival benefit. And also in RFPFS, there is a benefit of approximately 5 months. Just to complete the list, there are new targeted therapies also available. FDA has approved olaparib and rucaparib in 2020 based on PROFOUND trial. It's a phase 3 trial. Is compared olaparib 300 milligram BD dose compared with the enzalutamide or abiraterone in the control arm, and it has shown survival and benefit of approximately 4 to 5 months. And olaparib, according to FDA, has been approved for somatic HRR gene mutation with at least BRCA or BRCA1 and 2 and ATM gene out of 14 genes. And rucaparib has been indicated for BRCA1 or BRCA2 gene mutated patients. So according to NCCN, the treatment for metastatic castration-resistant prostate cancer is divided into 4 categories. When there is no prior docetaxel and no prior novel hormone therapy, the preferred regimens are abiraterone, docetaxel, enzalutamide. All these are category 1 indication. And in certain condition, radium-223 can also be given for symptomatic bone mets. And patients having prior novel hormone therapy and no prior docetaxel, the preferred treatment is docetaxel, and olaparib can be given having HRR mutations. And with prior docetaxel and no prior novel hormone therapy, the preferred regimens are abiraterone category 1 and enzalutamide. This is again a category 1 recommendation. And those patients who are heavily treated with docetaxel and prior novel hormone therapy, new treatment like lutetium-177 has been recommended as a category 1. And depending on the case-to-case basis, various drugs can be also given. So in summary, we can say there are wide range of agents for metastatic treatment of metastatic CRPC in 2022, starting from androgen receptor axis agent, chemotherapy in form of docetaxel, cabazitaxel, lutetium, PMSA, radium, PARP inhibitor, olaparib. And overall, we can see that overall survival for metastatic CRPC has almost tripled in last 20 years. And we can see each agent has some survival benefit of 4 months, 5 months. And if patient can afford and he can get 3-4 lines of treatment, then there can be more improvement in overall survival. However, there are many challenges: toxicity, availability of drug, logistic, sequencing of drug remains there. So these are my acknowledgement, and I thank you all for your kind attention.
Thank you so much, Dr. Pramod, for such a nice lecture and such a nice elaboration.
Thank you,
so there are some questions in the chat box. One question is, what is the optimal duration of ADT? 2 years or more?
So according to ESMO guideline, they have referred for 2 years. So 2 to 3 years is the optimal duration. If you give more than 2 to 3 years, then the chances of side effects will be more. So optimum is 2 to 3 years in high risk prostate cancer, or even if metastasis also.
There are
Giving
two
beyond
questions.
3 years is having more toxicity. And there are trials also where intermittent versus continuous androgen deprivation therapy has been tried, like given for 7 to 9 months, then 2 to 3 months of break. So there are also trials for giving intermittent ADT.
Dr. Pramod, Dr. Beg has some questions for you. Dr. Beg, you can ask.
Okay, I'm unable to see.
Actually, he has not put in chat box. He has raised his hand. I'm giving access to him.
Am I audible?
Yeah,
Yes,
you
sir,
are
you are audible. Good evening, sir.
Good evening, Dr. Pramod. I congratulate you for a very, very nice and elaborative lecture. And
Thank
you
you.
go in depth and trial everything. My question is absolutely very simple question. Like one thing, as the age is advancing, the average age in India, precisely in our country, is increasing because of the good medical care and health care. So, what is the policy for a prostate screening we are currently following? My one question, and the second question is what is the role of precision medicine? Is there any relevance of precision medicine in case of prostate cancer? Thank you.
Okay, sir. Thank you. So regarding, sir, with increasing age and prostate screening program, so this was dealt in great detail by Professor Kirti Srivastava in the first lecture of this prostate series. So as per my understanding, the prostate screening is not routinely recommended. And if the life expectancy is more than 10 years and patient age is less than 70 years, then in some cases it should be offered because it has its own pros and cons. And regarding your second question regarding precision medicine, if you mean by precision medicine like targeted therapy or immunotherapy, like I have shown olaparib and olaparib 300 milligram BD in PROFOUND trial has shown benefit of 5-year overall survival benefit. And there is also immunotherapy, but in the interest of time, I have not discussed in great detail.
Dr. Pramod, actually, I would like to add here.
Yeah.
In the recent ISMO guidelines,
Yes.
suggest there is no requirement of prostate population-based prostate screening.
Yes.
Same we are following. And then the second line, they have suggested that in case a patient is having a more than 10 years of life expectancy, the prostate screening is not required. And then third things they have suggested, the prostate screening is suggested only in high-risk cases. And then what are the high-risk cases? The patient who are having more than 50 years of age, as well as on their biopsy and immunohistochemistry, they have a germline mutation, BRCA1 and BRCA2. So they have that is the risk. Or regarding this second question, regarding what is the relevance of the precision medicine in prostate cancer, what actually we see here, if we go for an immunohistochemistry of prostate cancer, then we find the most commonly the 20% cases are germline mutation, and they are having a BRCA1 and BRCA2 mutations, or more precisely and more commonly the BRCA2 mutation. If you get an information from BRCA2 information, I'm talking about the importance of this. If you get in a BRCA2 mutation, then automatically you must be sure that the patient is going to have a pelvic lymph, going to have a distant metastasis, going to have a CLASS score more than 8, and going to have a poor prognosis with high-grade prostate cancer. So that case, that you have to change the treatment plan that docetaxel and platinum-based chemotherapy, as well as the polymerase inhibitor, that is the pembrolizumab, should be advised. So they have we are practicing what that is not important, but what we should actually be aware of. In case we want to go for a high stratification of management, then we should think of getting the immunohistochemistry for prostate cancer, and then we can reveal these things by exploring the advantage of precision medicine.
Yes, sir. Fair enough. Only thing, we have so many logistic issues.
That's another. Logistic is everywhere.
Yeah.
What is the actual we should do? We should be aware.
Yeah, and we hope in future we'll be doing in more patients this type of mutation study, and accordingly precision medicine-based treatment will be offered to patients.
Yeah, Dr. Pramod, we have another question. What is the role of CLASS cell therapy? CLASS cell therapy.
Yeah, it's so it's the immunotherapy, and as I have shown in my slides, according to NCCN, those patients who are previously treated with novel hormone treatment without docetaxel, they can be given this immunotherapy, and patients who are previously treated with docetaxel and novel hormone-based treatments in metastatic CRPC, again, it is recommended, it can be offered. So there is no single indication. So treatment of CRPC depends on many factors. What is the previous treatment given? And in future, we will be seeing more and more patients receiving more targeted therapy and immunotherapy. As of now, very less number of patients are receiving these treatments. There are other targeted therapy like olaparib and then lutetium-177. So these are more common as compared to immunotherapy in prostate cancer.
Dr. Pramod, I had two questions. Basically, what is the role of bone protective agents in metastatic hormone sensitive and metastatic castration-resistant prostate cancer? Is there any difference? Yeah,
ma'am. There is difference in skeletal related events. There is, as far I could find, there is no significant difference in overall survival. But there is, with denosumab, there is 20 months versus with Jolidonate around 17 months. So 3 to 4 months additional benefit in skeletal related events with denosumab. So this is there.
In castration resistant?
In both the groups, ma'am.
Okay. Yeah. Basically, there is no evidence which is favoring bone protective agents in metastatic hormone sensitive agents.
It is more in hormone sensitive.
And what's about the oligometastasis in CA prostate?
Ma'am, oligometastasis like defined as low when there is a low volume of disease. When the number of metastasis is 3 or 5, some trials have taken less than 5 mets or less than 3 or 4, plus lack of visceral metastasis. So they should be treated like low volume or low burden from either hormone sensitive prostate cancer or castration resistant prostate cancer. So
one last question from my side also. As you have mentioned that testosterone castration level below 50 nanogram per day, no? But I have read somewhere that if castration level is below 20, then it is a better biochemical relapse-free survival. I just want to know, is this true, or is there any evidence regarding this?
Ma'am, I have no idea. I need to read it. Maybe other expert who, I think Professor Neeraj Rastogi sir is there.
Sir, I think I have to search him.
Okay.
Wait.
I signed the participant list. What I found.
Sir has left. Yeah, sir is here. Sir is here. Sir, so Dr. Neeraj sir. I have given him access. Dr. Neeraj sir, can you hear us?
Yes, I can hear you.
Yeah, just one question, sir. What is the ideal castration level? Is there any difference between below 50 or below 20?
Actually, till now we know only less than 50.
Okay, sir.
The guidelines I have seen, ESMO, ASTRO, and NCCN, they have mentioned less than 50 only, ma'am.
Yeah, less than 50. It is only less than 50.
What is the role of debulking prostatectomy in high risk, high volume disease? Is there any role?
Ma'am, high volume means localized prostate cancer or hormone sensitive or
It's a hormone sensitive metastatic.
So, I mean, if the Stampede trial has shown benefit of adding RT.
But
So
not cytoreductive surgery.
Yeah.
Okay,
So, no, ma'am, can you rephrase your question, ma'am?
Pardon?
Can you rephrase your question or
Yeah. I just want to know what is the role of cytoreductive prostatectomy?
Okay, surgery.
Yeah.
Okay. No, Stampede trial has studied role of RT in low burden non-metastatic or metastatic hormone sensitive prostate cancer. Cytoreductive surgery, according to NCCN guidelines, they have shown you can do, but in most of the cases there will be margin positivity, and more often you need to give adjuvant, either early RT or salvage RT. So the toxicity will be higher, both surgical toxicity and radiation
Combined
toxicity.
modality toxicity.
Combined modality treatment. So usually they are not recommended. Yeah. Yes, sir.
Dr. Pramod, one thing is there, nowadays the oligometastasis is quite in fashion for a treatment of prostate cancer and a few of the cancers, where the people are trying, that's metastasis in the, metastasis there in the localized area, less than 5 metastasis, is amenable for a surgery or oblique radiotherapy, precisely in form of SBRT. So, in the prostate cancer, they are trying very high level. Let's say the prostate metastasis is limited in the liver, less than 5 number, or somewhere, but the zone has to be same. It is not there in the one metastasis there in lung, one is there in the prostate. The surgery cannot be done in that, but this radiotherapy in a form of SBRT is mostly applicable. Then you can go for SBRT for a one metastasis and one SBRT as well. And they have feel that there are some advantages we are getting. So far as the cytoreductive surgery in prostate cancer is still now is not being recognized as of now by ESMO or by ASTRO. That is cytoreductive surgery. The reason is very simple. We are not dealing with the hormone which is being released by the testes. Is not only one challenging factor. There is another challenging factor. The hormone is being released by adrenal gland as well. So it is not a cytoreductive surgery. Till now, there is no effective product.
I agree with you, Dr. Bay.
Okay, ma'am. Based on the Stampede data published in Lancet 2018, we should give local RT to prostate. That is better as compared to cytoreductive surgery.
Yeah,
because data is there, evidence is there for RT to prostate. Either hypofractionation, 36 grain 6 fraction, or ultra hypofractionation. Yes.
So thank you so much, Dr. Pramod. We have no more question here. And thank you again for such a nice and elaborated lecture on prostate cancer. Thank you, Dr. Bay, for such a nice interaction. Thank you, other participants. Good night, everyone. Thank you.
Thank you. Thank you very much, ma'am.
Thank you, Dr. Pramod. Thank you, Dr. Sylvie.
Thank you, Rastogi sir. Thank you, Beck sir.
Thank you, Rastogi sir, for grilling me badly yesterday. I've been grilled, and I love to be grilled by my teachers and my superiors.
Rastogi sir, can you comment or
no comment required.
Rastogi sir, are you there?
Hey, I think sir has left now.
Okay, anyway. No
time is over. Okay. So thank you so much once again, Dr. Pramod. Thank you all the participants. Thank you.